Okay, so imagine you're at the doctor and they just told you you've got atrial fibrillation.
Oh, yeah.
It's
Big news.
yeah, it's a lot to take in,
Absolutely.
especially when you start hearing all this medical jargon being thrown around,
Yeah.
and you're trying to make sense of it all and
Yeah.
figure out what it all means for you. It's a lot.
It is.
But that's why we do these deep dives, right?
Exactly.
To try to help break it down. We've got this stack of articles. They're all about the latest atrial fibrillation guidelines from, some of the biggest cardiology societies around the world.
Yeah.
And we're going to try to make sense of it all for you.
We are, and a big thank you to London Heartbeat Z Academy in the UK for their support in making this deep dive happen.
Yeah.
If you're interested in expanding your knowledge on this topic or other medical topics, they offer over 150 popular courses.
That's awesome.
Don't forget to subscribe to their social media channels on Facebook, Instagram, Spotify, and YouTube for free, regular updates. You won't want to miss any of our great discussions.
Right. So we're looking at 3 sets of guidelines today.
Okay.
We've got the European Society of Cardiology.
The ESC.
Yep, the ESC. We've got the American College of Cardiology, the American Heart Association, American College of Clinical Pharmacy, and the Heart Rhythm Society.
Mouthful.
Yeah, which we'll call the ACCP, HRS for everyone's sanity.
Yeah.
And we've also got the Canadian Cardiovascular Society, or the CCS.
Right.
And they all kind of come from the same basic science, but they've got these interesting differences.
Yeah, they do. One of the first things you'll notice is a ton of acronyms.
Oh, yeah.
The ESC uses AF care, for example.
Okay.
Which emphasizes the importance of, addressing comorbidities.
Right.
First and foremost. And that's followed by avoiding stroke, managing heart rate and rhythm, and then individualizing the evaluation and follow-up for each patient, right?
So it's not just about the heart itself, but looking at your whole health picture. Right?
Exactly.
Okay.
And the ACCP HRS guidelines use their own acronym, head to toes.
Wow, I like that one.
It's a good one. For heart failure, exercise, arterial hypertension, diabetes, tobacco, obesity, ethanol, and sleep.
It's like a checklist almost.
Yeah. And then they also have SOS
Okay.
for stroke risk and treatment, optimizing risk factors, and symptom management.
So they both really emphasize comorbidities.
They do.
It's really important, huh?
Yeah. See the whole patient.
Yeah.
Not just, the irregular heartbeat.
Now, traditionally, we've always talked about atrial fibrillation in these categories.
Yeah.
Like paroxysmal, persistent, and permanent. Sometimes people call it the PPP pattern.
Sure.
But the guidelines are suggesting maybe that way of thinking is getting a little outdated.
Yeah, that time-based classification, it doesn't always capture the true burden of AFib for each patient.
Right.
And it doesn't predict recurrence risk very well.
So it's not just about how often it happens, but like how much it's impacting your life.
Yeah.
And if it's likely to come back.
Yeah.
Even if you haven't had it in a while.
Exactly. So the ACC-HRS, they came out with this new 4-stage system.
What?
It looks at AFib as a progressive disease. Stage 1 is the, initial development.
Right.
And then stage 4 is permanent AFib.
So it's not just like a static condition. It's more like how it might evolve.
Exactly. Yeah. And the CCS guidelines, they look at it a little differently. They classify it based on the cause.
Oh, interesting.
So they use primary when it's, established,
Okay.
and secondary when it's linked to, like, potentially reversible factors.
So they're trying to get at the root cause.
Yeah. And, that kind of leads us to the topic of prevention.
Right.
Which both the American and European guidelines really prioritize.
So even if you don't have it, there's things you can do to lower your risk.
Definitely. Lifestyle modifications are really crucial.
Yeah.
Things like keeping a healthy weight, exercising regularly, avoiding nicotine and excessive alcohol, and managing your blood pressure and diabetes if you have them. All these things can really make a difference.
It's like a recipe for good overall health.
Yeah.
Which in turn is good for your heart rhythm.
Exactly.
What about screening? Should everyone just be screened for AFib?
Well, that's where the guidelines kind of diverge a little.
Yep.
The ESC and CCS recommend screening, especially for older individuals, but the ACCP-HRS are a bit more cautious.
Why the difference?
So the CCS focuses on cost effectiveness.
Okay.
They recommend opportunistic screening in patients 65 and older, so basically checking for it during routine visits.
Gotcha.
The ESC, they recommend systematic screening for anyone 75 and older, or those at high risk of stroke.
Okay.
So they want to actively look for it. But the ACC-CPHRS, they're not quite convinced. They say there's not enough evidence to support widespread screening for everybody.
Hmm. So that's one where you would definitely want to talk to your doctor.
Absolutely.
Weigh the pros and cons.
Yeah.
Based on your own situation.
Exactly. Now let's talk about something really important, which is stroke prevention.
Okay.
This is something that all the guidelines emphasize, but they don't all use the same tools to assess risk.
Right. So how do they figure out who's at risk?
So the ACC PHRS, they use the CA2-DS2 VASCUS score.
Okay.
Takes into account things like age, history of stroke, high blood pressure, diabetes, vascular disease, heart failure, and even gender.
Oh, interesting.
The ESC uses the CH2-DS2 VA score,
Okay.
which leaves out gender.
Why would they leave out gender?
Well, they say the evidence for female sex as an independent risk factor for stroke and AFib is weak.
Hmm.
And they point out that including gender can actually make things more complicated,
Okay.
especially for people who don't identify as male or female.
That's a good point.
So they're trying to be more inclusive.
Okay, makes sense. What about the Canadians? What do they use?
The CCS, they stick with the SHE-CADE S65 score.
Okay.
It's mostly focused on age and history of stroke.
So a bit simpler.
Yeah, more streamlined. But, some people argue it might miss some important risk factors.
Yeah, I can see that.
Yeah,
So using different scoring systems, you could end up with different recommendations for treatment.
absolutely. Like, imagine a 70-year-old man, no other health problems.
Okay.
The CCS guidelines, using just SHE-65, they'd probably recommend anticoagulation. But the ESC and the ACCP-PHR, with their more detailed scores, they might not.
Wow, okay.
On the other hand, you could have a 50-year-old woman
Okay.
with peripheral artery disease.
Okay.
The CCS would probably say just antiplatelet therapy,
All right.
but the other guidelines might recommend anticoagulation.
Wow, that's a big difference.
It is. It really shows how the scoring system can affect decisions.
Yeah, it's really interesting. And when it comes to actually choosing an anticoagulant, the guidelines generally agree that DOACs, or direct oral anticoagulants,
Right.
are preferred over VKAs, which are vitamin K antagonists,
Yep.
for eligible patients. Can you explain what those are and why DOAC is preferred?
Sure. So DOACs are now like the go-to choice for preventing stroke in most AFib patients.
Okay.
They're just as effective as VKAs, which are the older blood thinners, but they have a lower risk of bleeding.
That's great.
Yeah, and
Yeah.
bleeding is a big concern for
Oh.
people on blood thinners.
Definitely.
So it's a big advantage.
Fewer side effects and just as effective.
Exactly.
That's what we want.
Yeah. Although the ESC does add a little bit of caution,
Okay.
they advise against switching to a DOAC in patients over 75 who tolerate VKAs well and are already on multiple medications,
All right.
just to minimize bleeding risk in that age group.
Makes sense to be extra careful with older patients,
Mm.
especially if they're already on a lot of meds. Now, I know there's also LAAO
Yeah.
for stroke prevention in AFib. Can you tell us a little about that?
So LAAO stands for left atrial appendage occlusion.
Okay.
It's basically closing off this little pouch in the heart called the left atrial appendage. That's where blood clots often form in AFib, and those clots can lead to stroke. So it's like physically blocking the source of the problem.
Gotcha. So it's for people who can't take blood thinners.
Yeah, it's a good alternative.
Yeah.
For patients at moderate to high risk of stroke, but who can't take blood thinners, for whatever reason, they might have other medical conditions, or they might be at high risk of bleeding.
Right. Are there any differences in how the guidelines approach LAAO?
There are some nuances, like the ESC and the ACC-PHRS, they have slightly different recommendations on LAO for patients with a moderate to high stroke risk.
Okay.
And the CCS is a little more restrictive when it comes to surgical occlusion.
So even with LAO, it's not a one-size-fits-all.
No, it really depends on the individual patient
Yeah.
and the expertise of the healthcare team.
Yeah.
Recent research, like the LAAS third trial,
Okay.
that has influenced the latest recommendations,
Okay.
especially in the ESC and SAC-PHRS guidelines.
That's good. They're keeping things up to date.
Yeah, it's a dynamic field.
Now, I know there are also some specific situations where anticoagulation is particularly important
Yeah.
in AFib. Can we talk about those?
Sure. Let's start with cardioversion,
Okay.
which is a procedure that's used to restore normal heart rhythm.
So if your heart is beating irregularly because of the AFib,
Yeah.
you do this to kind of get it back on track.
Exactly. And to minimize stroke risk during and after the procedure, all the guidelines say anticoagulation is really important.
Okay.
They recommend at least 3 weeks of anticoagulation before a planned cardioversion
Okay.
and before an unplanned cardioversion, like in an emergency.
Yeah.
They recommend doing a transesophageal echocardiography,
Right.
or a TOE,
Okay.
to rule out any blood clots in the heart.
So that's like an ultrasound of the heart.
Exactly. It's important for safety.
Gotcha.
Now, there are slight variations in how the guidelines approach new onset AFib.
Oh, right. New onset meaning AFib that's just started.
Yeah, they have different recommendations. For managing stroke risk in those cases, depends on the patient and the situation.
Right. So again, it's personalized.
Yeah. Personalized decision-making is key.
What about catheter ablation?
Right. So catheter ablation, that's a procedure that uses energy to create tiny scars in the heart
Okay.
to disrupt the electrical pathways that are causing the AFib.
Okay.
And whether or not the procedure is successful,
Right.
all the guidelines recommend starting and continuing anticoagulation before, during, and after the ablation.
Really? So even if it fixes the problem, you still need blood thinners?
Yeah, because studies have shown that even after successful ablation, there's still a higher risk of stroke in the period right after the procedure.
So it's like extra protection during a vulnerable time.
Exactly. Yeah.
Hmm.
Minimize risks, ensure the best possible outcome.
Now, there's this thing called device-detected AFib,
Right.
which the ESC calls subclinical AFib. What is that all about?
So that's when you have these brief episodes of AFib that are picked up by like implantable devices. Okay. Pacemakers or defibrillators, or even wearables like smartwatches.
Oh, wow.
And you might not even have any symptoms.
But you could have it and not even know it.
Yeah, it's a hot topic right now in cardiology.
Yeah.
And the significance of these subclinical episodes is still being debated. The ACC HRS guidelines, they recommend personalized decisions about anticoagulation based on how long these episodes last and your stroke risk.
Okay.
But there have been some new trials.
Oh, right.
The NO, AFNet-6, and Artesia trials.
Okay.
These have kind of changed things. The ESC guidelines now take a more conservative approach.
Okay.
They recommend DOAC therapy, but only in certain cases,
Okay.
specifically for people who aren't at high risk of bleeding.
So they're saying in some cases the risks of the blood thinners might outweigh the benefits.
Right. And the CCS guidelines, they haven't addressed this issue specifically yet.
It seems like subclinical AFib is still a bit of a mystery.
It is. It's evolving as we learn more.
And lastly, we have postoperative AFib, which is AFib that happens after surgery, right?
Right. It's a pretty common complication. And the guidelines offer different ways to manage stroke risk in these cases.
Okay, so what are the main differences?
Well, the ESC, they recommend long-term anticoagulation for patients who have postoperative AFib
Okay.
and have an elevated stroke risk.
Well.
So that's a more proactive approach,
Right.
trying to prevent stroke right away. But the ACAC, ACPHRS, and the CCS, they recommend reassessing stroke risk
Well,
after a certain amount of time.
right.
They say waiting to see if the AFib sticks around.
Right.
Before starting long-term anticoagulation, that could actually reduce mortality
Okay.
without increasing stroke risk.
So it's kind of a balance
Yeah,
between preventing stroke and not overdoing it with the blood thinner.
exactly. It shows how complex decision-making can be in AFib management,
Yeah.
especially in specific situations.
Yeah. Well, we've covered a lot of ground. In this first part of our deep dive, we've talked about different ways to classify AFib, the importance of comorbidities and prevention,
Yeah.
the nuances of stroke risk assessment, and all the different options for anticoagulation.
A lot of info.
Yeah.
And we've only just scratched the surface.
I know there's so much more to discuss.
There is. So welcome back to our discussion. We're now moving into, what some might call a new era in AFib management.
Oh, how so?
Well, it's all about the shift towards earlier rhythm control strategies.
Okay, so instead of just focusing on controlling the heart rate, we're now talking about actually trying to restore a normal rhythm sooner.
Exactly. And you see this reflected in all three sets of guidelines that we've been looking at.
Interesting. What's driving this change? Is there new evidence that suggests that early rhythm control is actually better?
There is, actually. Studies like the East AFNet 4 trial, that's a big one, they've shown that intervening early can lead to better outcomes for patients. So starting rhythm control therapy sooner rather than waiting for things to get worse can reduce the risk of cardiovascular events. Things like stroke, heart failure, and even death.
Wow, that's pretty significant. I mean, it makes sense intuitively that restoring a normal rhythm would be good, but it's good to have the research to back it up.
Yeah, absolutely.
So who are the patients that would benefit most from this early rhythm control?
Well, the guidelines generally recommend considering it for a few groups. Those who have really bothersome symptoms from their AFib, younger individuals with fewer comorbidities, and those with recent onset AFib.
Okay, so it sounds like, once again, personalized medicine is really important.
It is. You have to consider each patient's situation, their preferences. It should be a collaborative decision between the patient and their doctor
Wow.
to weigh the potential benefits and risks.
Right, absolutely. Now, what about rate control? If a patient isn't going the rhythm control route, what are we aiming for when it comes to managing their heart rate?
Well, if rate control is the primary strategy, then the goal is to achieve a target heart rate. But here's where things get a little interesting because the guidelines actually have slightly different recommendations.
Oh, really? So what are the differences?
So the ESC guidelines, they're the most lenient. They recommend a target resting heart rate of below 110 beats per minute.
Okay.
They say this is usually enough to relieve symptoms without being overly aggressive.
Okay, makes sense. What about the American guidelines?
The ACCP HRS guidelines are a bit stricter. They recommend a target of under 100 to 110 beats per minute
Okay.
for patients with normal left ventricular function. And they base this on evidence that suggests tighter control in this group might be more beneficial.
Okay, so a bit more stringent, but still with some flexibility. What about the Canadians? Where do they fall in this?
The CCS guidelines recommend the tightest control, a resting heart rate below 100 beats per minute, especially for patients with reduced ejection fraction. So this more aggressive approach is based on data that suggests this tighter control is better for patients with heart failure. It can improve their outcomes.
It's interesting to see how all three guidelines interpret the evidence and come to these slightly different recommendations.
It is. It's a reminder that this is a dynamic field. As we get more research, our understanding of AFib management continues to change.
Absolutely. So how do we actually go about achieving rate control? What are the tools that we have?
Well, medications are still the mainstay of rate control in AFib.
Okay.
3 main classes are commonly used: beta blockers, calcium channel blockers, and digoxin.
Okay, can you break those down for us a little?
Sure. So beta blockers work by slowing down the heart rate and reducing the force of heart contractions.
Okay.
They're often the first choice, especially for patients who don't have significant lung disease.
Right. And what about calcium channel blockers?
Calcium channel blockers, they also slow down the heart rate,
Okay.
but they do it through a different mechanism. They're particularly effective in patients with high blood pressure,
Yep.
and they can be used alone or in combination with beta blockers.
Okay, and then there's digoxin, which I know has had a bit of a, shall we say, controversial past.
Yeah, that's true. Digoxin has been around for a long time in AFib management, but its role has been kind of reevaluated recently. The RATE-AF trial showed that digoxin is actually comparable to beta blockers
Okay.
in terms of quality of life for patients with permanent AFib, and that's led to some changes in its recommendations.
So it's making a bit of a comeback.
You could say that, but it's important to use it carefully and to monitor for side effects.
Right, it has a narrow therapeutic window.
Exactly.
What happens if medications aren't enough to get the heart rate under control? Are there other options?
There are. If medications fail, then a procedure called atrioventricular node ablation might be considered.
Okay, that sounds pretty intense. What does that involve?
So basically, it involves using energy to create a small scar in the heart. This disrupts the electrical pathway that allows those rapid signals from the atria to reach the ventricles. So by blocking this pathway, you can regulate the heart rate.
So it's like creating a roadblock for those rapid signals.
Yeah, that's a good way to think about it. And while it might sound scary, it's actually a relatively safe and effective procedure, often done in a minimally invasive way.
Okay, when would this procedure typically be considered? Is it a last resort?
Generally, all the guidelines recommend it when rate control can't be achieved with meds alone, and when efforts to restore normal rhythm haven't worked.
Okay.
So it's often considered in elderly patients, those with pacemakers or defibrillators, and those with cardiac resynchronization therapy where biventricular pacing hasn't been effective.
Right, so it's a good option for those who haven't responded to more conservative approaches. Okay, let's switch gears a little bit and talk about rhythm control strategies in more detail. What are the tools we have when we're trying to restore that normal heart rhythm?
Well, the first decision is often between electrical or pharmacological cardioversion.
Okay, can you explain the difference between those two?
Sure. Electrical cardioversion involves delivering a controlled electrical shock to the heart,
Okay.
which essentially resets the rhythm. It's often done in a hospital setting under sedation because it can be a bit uncomfortable.
Right, and then pharmacological cardioversion.
Pharmacological cardioversion uses medications, usually antiarrhythmic drugs, to convert the AFib back to normal rhythm.
Okay.
This can be less invasive and can sometimes be done on an outpatient basis, but it might take longer to work.
Okay, so the choice between the two really depends on the patient's situation, potential side effects, and how urgently they need to restore that normal rhythm.
Exactly. And it's worth noting that the ESC guidelines, based on the RACES 7A WAS trial, actually suggest a watch and wait approach for stable patients with recent onset AFib.
Well, that's interesting. So sometimes you might not need to do anything right away.
Right. It's based on the observation that in some cases, especially if the AFib has just started, it might actually resolve on its own.
Okay.
This is particularly relevant for patients who are stable and not experiencing bad symptoms. But of course, this decision should always be made with a doctor.
Right. It's not a one-size-fits-all approach.
Exactly.
Okay, so for those who are undergoing electrical cardioversion, what are some of the key considerations?
Well, all the guidelines agree that biphasic shocks are the preferred method. These deliver energy in two directions. And they also emphasize using enough energy to make sure the conversion is effective.
Okay.
The specific electrode position and energy level are determined by the healthcare provider, based on the patient and the type of AFib.
So it's a little more nuanced than just zapping the heart back into rhythm.
It is, yeah. Safety and effectiveness are crucial.
Of course. Now let's talk about pharmacological rhythm control. What kinds of medications are used for that?
So, there are several antiarrhythmic drugs that can be used for both cardioversion and long-term rhythm control. The choice of drug often depends on things like the patient's other medical conditions, potential side effects, and drug availability.
Makes sense.
Huh.
Can you give us some examples of these antiarrhythmics drugs?
Sure. Flecainide and procafenone are often recommended as first-line choices for cardioversion in patients who are eligible.
Okay.
They're effective at converting AFib back to normal rhythm and are generally well tolerated.
Okay. Good to know. What about amiodarone? I've heard that one a lot.
Yeah, amiodarone is very effective at maintaining normal rhythm, but it's not usually the first choice because of its potential for long-term side effects and its delayed onset of action.
Okay.
So it's often reserved for patients with more complex cases or those who haven't responded to other medications.
So it's a powerful tool, but one that needs to be used carefully.
Exactly.
Now, what about long-term rhythm control? Are the same medications used for both cardioversion and long-term maintenance?
Some are, but there are some important things to consider for long-term therapy. Flecainide and propafenone, they're great for cardioversion, but they have some restrictions for long-term use.
What kinds of restrictions?
Well, they're not typically recommended for patients with structural heart disease or coronary artery disease.
Okay.
They can increase the risk of dangerous heart rhythms.
I see.
Although there's a little bit of debate about this, the ACCP HRS guidelines are a bit more liberal with their use in certain patients.
Okay.
But generally, they're not the first choice for long-term therapy in those patients.
So again, it's about balancing effectiveness and safety. What are the other options for long-term rhythm control?
Amiodarone is still commonly used, despite those potential side effects, especially for patients with heart failure and AFib.
Okay. Are there any alternatives to amiodarone for those who can't tolerate it or who are worried about the side effects?
There are a couple. Drondarone can be an alternative, but it's not as effective, and it should be avoided in patients with moderate to severe heart failure. Sotalol is another option,
Okay.
but it's often considered second line because it can sometimes trigger abnormal heart rhythms.
So it seems like choosing the right antiarrhythmic drug is very individualized.
It really is. You have to know the patient's whole situation and weigh the potential risks and benefits.
Absolutely. Now, there's another approach to rhythm control that seems to be getting more and more attention, which is catheter ablation.
Right.
Can you tell us more about that?
Catheter ablation is a minimally invasive procedure that uses energy to make tiny scars in the heart. These scars interrupt the electrical pathways that are causing the AFib.
Okay, it's like creating those targeted roadblocks.
Exactly.
So who are the best candidates for this?
Well, younger patients with symptomatic paroxysmal AFib tend to have the best outcomes. And we're actually seeing a shift towards considering ablation earlier in the treatment process, especially for paroxysmal AFib.
Oh, so it's not seen as a last resort as much anymore.
Not as much, no. The evidence is really growing, showing that it's both effective and safe. In fact, the ESC guidelines have upgraded their recommendation for first-line catheter ablation in paroxysmal AFib.
Wow. Sure.
It's now a Class 1 level of evidence of recommendation. That's a very strong endorsement.
Yeah, it shows a lot of confidence in the procedure. So are all ablation procedures the same, or are there different techniques?
There are different approaches, but pulmonary vein isolation, or PVI, that's the cornerstone of most procedures.
Okay, what exactly does PVI involve?
So the pulmonary veins, those are the blood vessels that carry oxygen-rich blood from the lungs back to the heart.
Right.
And in AFib, these veins are often the source of the electrical signals that trigger the irregular rhythm.
Okay.
So PVI aims to isolate those veins from the rest of the heart to prevent those signals from causing problems.
I see. So it's like cutting off the problem at the source.
Exactly.
And the guidelines generally agree on PVI. But what about other ablation techniques?
There's less consensus on those. It's still an evolving field.
So new techniques are still being developed and researched.
Definitely.
It's amazing to see how much progress is being made in AFib management.
It really is.
And I'm sure there's a lot more to come.
Absolutely. The future is full of possibilities.
Wow. It's amazing to think about how far we've come in managing AFib. From just controlling the heart rate to actually restoring rhythm, and from traditional blood thinners to these innovative procedures like LAAO and catheter ablation. It's really exciting.
It is, and the future of AFib management is just full of possibilities. Researchers are really pushing the boundaries, and we're seeing new treatments, new diagnostic tools, more personalized approaches. It's really incredible.
It feels like we're on the verge of a whole new way of thinking about AFib.
I think that's a good way to put it. Even the very definition of AFib might change. Right now, we diagnose it based on at least 30 seconds of irregular rhythm, but that could evolve as we learn more.
So the length of the irregular rhythm might not be the only thing that matters.
Right. AF burden, that's the total amount of time someone spends in AFib, is becoming more and more important. It's not just about the individual episodes, but the overall effect on the heart. That might change how we make decisions about anticoagulation. And it could become a key way to measure how well rhythm control strategies are working.
It makes sense to look at the bigger picture, not just isolated events.
Exactly.
Yeah.
And speaking of looking at the bigger picture, lifestyle modifications are going to be even more important in managing AFib. Things like diet, exercise, stress management, sleep, all of these things play a role. And research is ongoing to develop more personalized lifestyle interventions.
This is like a personalized prescription for healthy living.
Yeah, I like that. It's about empowering patients to take control of their health.
What about screening? We talked earlier about how the guidelines have different recommendations for AFib screening. Do you think that's going to change in the future?
It's hard to say for sure. We need more evidence from large-scale studies to know for certain who would benefit most from screening and what the best screening strategies are. Like what's the best age to start? How often should you be screened? What's the most effective way to do it? EKGs, wearable devices, a combination.
Yeah, there are a lot of questions still to be answered.
There are, but that's what makes it so exciting. There's so much room for discovery. And speaking of exciting new developments, wearable devices are playing a bigger and bigger role in AFib detection.
Yeah, it seems like everyone has a smartwatch or fitness tracker these days. But can they really detect AFib accurately?
That's what we're trying to figure out. The technology is promising, but we need to make sure they're accurate and figure out how to best use them in clinical practice. Like, if your smartwatch says you might have AFib, what do you do next? You need to see your doctor right away? Are there ways to tell the difference between real AFib and other, less serious heart rhythm changes?
Yeah, this sounds like we're still in the early stages of figuring all that out.
We are, but the potential is huge. Imagine a future where these devices not only detect AFib, but also give you real-time feedback and guidance to manage your condition.
Like having a little cardiologist on your wrist.
Exactly. And that brings us to personalized medicine. The future of AFib management is probably going to be much more individualized. Treatment decisions tailored to each patient's specific genes, lifestyle, risk factors.
It's moving away from that one-size-fits-all model.
Exactly. Even in stroke prevention, we're already seeing a shift towards more personalized approaches. Researchers are developing new risk scores that go beyond the traditional factors, like age and medical history. They're looking at genetic markers and biomarkers to get a more accurate picture of each person's stroke risk.
That's really incredible. So not only is AFib management becoming more effective, it's also becoming more personalized and proactive.
That's the goal. And of course, the search for new treatments is constantly ongoing. New anticoagulants are being developed, focused on making them even safer and more effective.
So fewer side effects and even better stroke prevention? That's great news.
It is. And beyond anticoagulants, researchers are also working on new antiarrhythmic drugs, ones that are more effective and have fewer side effects. There are also new approaches to rhythm control being explored, things like gene therapy and cell-based therapies, which could really revolutionize treatment.
It's amazing to think about all the possibilities.
Yeah.
It really does feel like the future of AFib management is bright.
It is. We've covered a lot in this deep dive, the latest guidelines, the controversies, the future of AFib, but the most important thing to remember is knowledge is power. The more you know about your condition, the better decisions you can make about your health.
That's so true. It can be really overwhelming to deal with AFib. But understanding the condition and your options really does make a difference.
Absolutely. And don't be afraid to ask your doctor questions. They're there to help you. Open communication is so important for good care.
Well said. Well, this brings us to the end of our deep dive into the world of AFib. We've explored the current guidelines, we debated the controversies, and we've looked ahead to the future.
It's been a great discussion, and I hope everyone listening feels more empowered to manage their health.
A huge thank you to London Heartbeat's Z Academy for their support in making this deep dive possible. To our listeners, we encourage you to check out their amazing educational resources. They have over 150 courses available. And don't forget to subscribe to their social media channels on Facebook, Instagram, Spotify, and YouTube for free regular updates.
That's right. And until next time, keep those hearts healthy and those minds curious.